The World Cancer Survivors Day, and on tonight's show we celebrate persons who have beat cancer after treatment. We'll also be raising issues around awareness and the existing challenges and the cancer burden in Kenya, which still remains a huge concern. And tonight I'm joined, starting from this end, by Dr. Elias Meli. He's the CEO, National Cancer Institute of Kenya. Many thanks for joining us, Dr.
Thank you.
We're also joined by Phoebe Ongadi, Executive Director, Kenya Network of Cancer Organizations. Thank you for joining us, Phoebe. And also joined tonight by Sydney Chahonyo, who is a cancer victor or warrior, if you like. Thanks for joining us, Sydney.
Thank you for having me.
Sydney, I'll begin with your story today, this being a celebration of persons that have survived cancer, and of course being very significant for families across the country that have, you know, a family member that may have been diagnosed, as well as persons who are undergoing treatment. So share a bit about your story with us. When were you diagnosed with cancer, and what type of cancer was it, and at what stage?
I was diagnosed with cancer of the postnasal space at the age of 19. This was in 2004. I just finished high school. I was about to, go abroad for further studies. And at that point is when I started getting the symptoms. And it was, by the time I was diagnosed, my oncologist told me that it was very early stage. So I was one of the more fortunate ones.
Right. Okay, so you were told it was, in terms of, and we want to talk about your experience with the diagnosis in terms of how it was communicated to you, fairly young, just straight out of high school, and you're given news that you have this type of cancer, although it's early stages. In terms of the diagnosis and how that was communicated to you, what was your experience with that?
Before I answer that, I'll start with the process of the diagnosis. It took about 6 months to get the correct diagnosis, and this is even going to the best hospitals, the Aga Khans, the Nairobi hospitals. It took about 6 months of misdiagnosis to actually get the proper diagnosis. I remember at the point of being told that I have cancer, I had gone in for a follow-up after doing my biopsy and doing my blood work, and I was sitting there with my dad, and at the point where the doctor said, "You have cancer," my mind just blanked out. Like, I completely don't remember anything else that happened for the rest of that day. But I remember seeing my dad balancing tears in his eyes. And that's the first time I'd ever seen my father looking vulnerable. So at that point, it was a bit of a shock. And as I said, it takes a lot to process it. There's a lot of mental strain that you go through. Start asking yourself questions. What exactly is happening? You almost want to pinch yourself to find out if I'm dreaming or if this is real. It takes a couple of days for you to accept that diagnosis. And also, at the same time, what's going to happen to me? But luckily, my oncologist was also very supportive. And he told me that he had handled cases like that before. It was cancer of the postnasal space, which is where your ear, nose, and throat meet. And apparently, it's very common in East Africa. But he told me that it was caught pretty early, and I had a very good chance.
Sorry for interrupting you. What symptoms were you experiencing?
Initially, just normal symptoms. First, I had flu symptoms, like I had a runny nose. Then I started having very mild headaches at the back of my head. Headaches that you drink water, you take pills, Panadol, what have you, and then also started nose bleeding. But with time, the symptoms got more severe. The headaches were more and more severe. The nose bleeding was more frequent. And that is when I started realizing there was a problem. But also because of where the cancer, the growth was, it was starting to block my hearing passage. So I started losing hearing, and that was actually the trigger for me.
Now, you talked about going through, and I'll get to Dr. and Phoebe shortly, you talked about going through a number of hospital visits before this diagnosis was actually made. In that process, because you talk about having been with your parent, in terms of the post-diagnosis, rather even before the diagnosis, the cost that was involved during that entire experience, before you even got into the treatment, did you get a scope of how expensive it was for you as a family to deal with that?
In terms of diagnosis, that was not the most expensive bit of it. Luckily, I did have health insurance. And, I'd go to a hospital, I'd be told you have to do these tests. So I'd do my MRI, I'd do my just normal blood work, I'd do certain tests. Eventually, it started being you need to do a CT scan, which were costing between 8,000 and 20,000 per scan. After that, you do a lot of blood work, and you keep doing this because you go to one doctor, he tells you need to do tests, and he tells you it's a sinus problem, and you say, let me get a second opinion, because you've been through that before, you've been given the pills, and you know it's something different. So you go to somewhere else, and you have to start the process again, because now you have to do another round of blood work. You have to do another scan, because the doctor will only move on scans that he has prescribed or scans that were done at that hospital. So it was a lot of repetitive costs. So I would say, I can't give you a figure off the top of my head, but every time I would see a new doctor within that 6-month period, I'd have to pay consultation fees, the cost of the diagnostic tests, and then also just, the moving around. It was also just stressful.
Yeah.
Yes.
Thanks for sharing that, Sidi, and I'll come back to you as we, of course, talk about your journey and where you are at now. Phoebe, in terms of the barriers to cancer care in Kenya, we're talking about how long it took for a diagnosis to actually be made. So in terms of the high rates of misdiagnosis, first of all, that we know have been known to exist, and the inadequate screening hindering early detection. Let's speak into that and how that affects the journey towards survival. As days go, the cancer is advancing. Perhaps when Sydney started going to hospital, like he said, he was told it's early stages. But for other people, they get to find out way later when the cancer is at a very advanced stage.
Thank you very much, Lillian. I think that it's very important to have the conversation of access. And as Sydney has said, is one of the lucky people who got the cancer early enough. But we are having a lot of barriers, like you have said, because when we look at access, we look at access in diagnosis, we look at access in detection, we look at access in treatment and care. We also look at access in all the aspects of cancer treatment and management. So the barriers in access actually are one of the challenges that we were highlighting today during the survivorship, because we are saying, well, we are saying we are celebrating survivorship, but are we really celebrating? The survivors are coming out to tell us that as much as we are surviving, there has been hurdles on the way. What about that person in the village, in unreachable areas, who are not able to access some of these services that maybe Sydney is also talking about? So barrier to early diagnosis, barrier to treatment, barrier to care is a real challenge to cancer survivorship.
Right, and Dr. Elias, still on that and staying on that beat, in terms of the burden of cancer treatment in Kenya, talking about repeat visits even before the biopsy, and now looking at the actual cost of cancer treatment in Kenya and what on average it would cost for even, chemotherapy, give and take. Where are we on that? Because a lot of Kenyans perhaps might not find themselves in a position where they can even afford, the luxury of going through repeat and routine chemotherapy. Others don't have insurance, or it's still hanging, in the balance, give and take. So in terms of cancer treatment and looking at survival rates in the country, before we even talk about people going to India, where are we?
All right. Thank you, Lillian, for having us tonight. And I want to begin by thanking God for those who have been able to breast through the cancer challenge. Today was, according to my understanding, one of the best days that we've had, those of us who are in cancer space for a while now, celebrating the success stories. When you get an opportunity to interact with those who have actually been diagnosed with this terrible disease, and they have gone through, the entire course of treatment, whether it's surgery, whether it's radiation, whether it's chemotherapy, we are really happy that we can have positive stories. For a long time, cancer has been dubbed death sentence. But for once, we had a huge team. We had a real festival. We sang, we danced. We thank God for, the favor and the grace that many, just like Sydney here, have been able to have over time. And going straight into your question, the burden of cancer, of course, in our country is rising. It's no doubt. And it's not only in Kenya, it's a global concern. It is a regional concern. And cost, as you mentioned, is one of the moving parts that influences survivorship. And it has been quite a challenge for most of our people to afford this treatment. And we are looking at cancer care across the entire continuum of care, and beginning with prevention. We are looking at early detection. We are looking at screening. We are looking at real diagnosis using either pathology or imaging and radiology. We are looking at treatment. And for you to treat cancer correctly, currently, unless you are able to go into the details of molecular characterization of cancer so that you do personalized treatment. We are no longer doing general treatment for our patients. If you have, 6 people with breast cancer, it is not the same disease.
Right.
You have to go into the genetic level and be able to characterize so that you can be able to do targeted treatment. We are at an era where it is doing what we are calling genomic characterization, so that we look at what is driving your disease.
Yeah.
And
Talking
this is
about
where
genomic characterization, and that's a question that came in when we teased this interview. When we talk about the cost of cancer treatment, we are made to understand that our genes, perhaps African genes and Caucasian genes, are different, and yet when you look at the cost of treatment, still remains the same. Talking about that and the fact that you're saying that this is very individual specific, it still remains a very expensive affair, irrespective of the fact that genes, differ.
Correct, because cancer is a genetic disease. We all know it begins with a mutation. There is an error that occurs in our genes. And our genetic instabilities and our variation in our immunities, the imbalance is what leads to this cell to multiply and ultimately becomes cancer. So if you have to address this challenge, you have to go back to the gene. And as much as we look at the Caucasian and the African population, even within our country, our Kenyans who live in the northern part of the country are different from those who live at the western part of the country. And it's different because there is what we call epigenetics. The environment, where you live and where you grow up, influences a lot on how your genes will look like. And as we approach diagnosis and treatment, we have to be guided by what we call biomarkers. And this is where the real expensive cost of cancer care comes in. And if we are to really work on making sure we increase survivorship, we have to do targeted treatment. We are no longer going to burn the forests to kill, a snake. We have to look for the snake and deal with it and leave the ecosystem. So we have been providing a lot of generalized treatment. If you talk about chemotherapy, when you ask me, Lillian, what is the cost of cancer care? I will not give you an answer. But if you ask me, what is the cost of a 59-year-old who has estrogen positive, breast cancer, then who is stage 3, we can then have a discussion, because then I will be very specific. Otherwise, I would say we have a range. We could say to treat breast cancer is different from cervical cancer, from postnasal space cancer, from brain cancer, from blood cancers, leukemias in children. So we can talk about range.
And we'll continue with that. Phoebe, I want to get back to you before I cross over to Sydney. When you looked at today's celebration and today's festival and looking at the survivors and their stories, what factors played a key role in terms of the better treatment outcomes for the people that you interacted with? And what are some of the issues that, lead to better treatment outcomes for people who might have had an early diagnosis, you're perhaps at stage 1 or stage 2, from the people you interacted with?
Yeah, so from the people we interacted with, what led to better treatment outcomes? Number 1 was family support. So most of them were saying, and that's why as KENCO and civil organizations, we advocate for psychosocial care. And May being a mental health month, we advocate for families and caregivers, because right now, Muli, almost everyone is affected by cancer. It is you are either sick or you know someone very close who is sick. And cancer right now does not look at your age, your background, your education and all that. Yeah. So one of the things they were saying is also the supportive access in the different hospitals that they come to, the caregiver attitudes, the healthcare workers' attitudes, and also the availability. And I think it's a reason to appreciate this government for especially the strides with the help of the civil societies, organizations like like Kenco and the rest, there has been really a progressive improvement even in the coverage of health insurance for these patients. So one of them is, which is currently under review, and we have had a sneak peek of it. It's better with the chronic illness care for the cancer patients. And so those are some of the reasons, because as you say, Lilian Muli, if you have a friend today with cancer, in a matter of time, you will find yourself in a WhatsApp group. But the survivors came out very strongly and saying, no, we have hospitals in this country, we have referrals in this country, they are actually treating cancer, there is no need to travel out. So the message that was there today was, there is hope. And if you look at statistics, like Dr. Meli was saying, you wouldn't find statistics on survivorship. You'll find the cancer burden, the new diagnosis, the yearly deaths. You'll find the devastating news. But there is a lot of survivorship out there. So the message that went out today was the message of hope and message of access, of family involvement, community involvement, and most of all, government involvement.
Thanks for that. Sydney, let's talk about your treatment journey and the involvement of family, the psychosocial support as well as the attitude of the caregivers. Share with us, first of all, were you treated here locally? Did you have to seek medical attention outside the country?
I did all of my treatment here in Kenya. I was treated at Nairobi Hospital. I started first with radiotherapy, and I did about, I would go Monday to Friday for about 4 months. And, you know, it's like getting an x-ray. So they put you in the machine, they target it, and they give you the therapy. So I did that for about 4 months. Initially, I didn't see any changes. But after about the third week, you start getting some of these side effects of the treatment. A lot of pressure on the brain, which eventually led to a point where I was just throwing up. You know, until there's nothing left in your stomach, but you're still trying to bring something up. Aside from that, I had very sensitive throat. Because of where the radiotherapy was being delivered, at some point it was hard to swallow water. Aside from that, I had some of the other symptoms include my taste buds. My taste buds were completely, at some point I couldn't taste any food. My saliva glands were also affected. So first of all, you're nauseous. You can't taste food. The smell of food even just makes you want to throw up. Even when you swallow the food, you have to have a bottle of water because it's very painful. Even yawning was painful. So those are some of the things I experienced with radiotherapy. And until now, it's still not 100%. After that, I did chemotherapy. And I would be admitted from between Monday and Wednesday to get my drug, carboplatin. I remember my chemotherapy drug. It was called carboplatin. And at that point, it even reached a point where we couldn't find it in Kenya. We looked everywhere, we couldn't find it. We looked in the US, we looked in the UK, eventually we found it in Dubai. And by the time we found it, one vial was going for 50,000 shillings. This is in 2004. So I did my chemotherapy. And what would happen is after the 3 weeks, after the 1 week of being admitted in the hospital, I would be sent home because if they keep giving you the chemotherapy, it's toxic, so it can poison you. Right. So I would need 3 weeks to recover from that bout of chemo. After 3 weeks, I would come and do some tests to see whether my body is strong enough to take the next bout. So after the 5th bout of chemo, I went and did my tests to see whether I could, continue with chemo before figuring out what's the next treatment modality. But at that point, the doctor told me there's no sign of cancer in your body.
So how long has it been now, and you look fine, you look and we celebrate you today, and thank you so much for sharing your story. How long has it been now? Do you still go for routine checkups? Do you still have to, visit your oncologist every once in a while to check that everything is still okay?
In December last year, actually in November last year, I celebrated 19 years of being cancer-free. So I've been cancer-free for 19 years. Initially, just after you're declared cancer-free, I started going in every 3 months to have my checks just to make sure that it's not going to come back or that they had, gotten everything. After a while, you start going every 6 months. Then after about 5 years, you start going every year. So even now, every year, I still have to do my checks. I'll go in and I'll do my blood work. I'll do various tests. Then I'll go and see my oncologist just to make sure that everything is okay.
Yeah.
Yes.
Thank you for that. Dr. Elias, before we take a break, we want to talk about remission. This debate has been quite rife in terms of, survivors celebrating years and years of being cancer-free. and then, you know, the unfortunate stories of persons who unfortunately have gone into remission before we take a break?
Well, thank you very much. I'm really happy that we are living at a time when our survivors can speak and give hope to those who have been diagnosed, who are still on treatment, that ultimately there is a possibility that they can be treated with curative intention.
Yeah.
Now, complete remission is a hot topic. A lot of patients would be excited after, you know, they complete their treatment. We are now providing, of course, an hybrid guided by biomarkers, as I mentioned, for diagnosis and for treatment. We are able to provide, whether it's surgery, systemic treatment, chemotherapy. We even have now the latest kid in the block called immunotherapy. We are modulating the immunity so that it can fight against the cancer cells. And this is where this, you know, discussions about vaccination comes in. How do we then? There are those who get surgery. There are those who get multimodality treatment. And after that, they are excited with their first imaging after 3 months or 6 months when they go back for review with their oncologist. And I face this all the time. And, you know, we treat patients based on, you know, evidence-based practice. You know, it's not witchcraft. It is protocols that are being used have undergone, you know, intense research to confirm that if you are going to get this combined treatment, you know, the chances of you going into complete remission is ABCD. And we are always excited when you get that first MRI, that first PET CT scan, that first CT scan or an ultrasound. And we are all happy that finally the disease disappeared. But wait until, unfortunately, 2 years, 3 years into follow-up, a patient presents with back pain. You know, some headache, maybe a cough. And of course, we would want at that point to consider, you know, re-imaging. And it's always quite unfortunate when we disclose that the disease could have recurred.
And that's what Phoebe was talking about in terms of caregivers' attitudes. Cancer has gone into remission, but in terms of the follow-up of the caregivers, the oncologists, and checking up on their patients, and you talked about the involvement of stakeholders, the Ministry of Health in terms of trainings, and what have you, Phoebe, talked about that. But in terms of the follow-up, you know, of patients, you find patients perhaps having to move from one oncologist to another because one oncologist said that you're in remission. You know, he's found that, you know, you're at a good space now. But then again, years later, you know, perhaps something happens and you're thinking, this oncologist said that I had gone into remission, hasn't followed up on what's going on with me, or at least there hasn't been that patient-doctor, you know.
So I think it's a valid concern. And from time to time, when I sit in the clinic and I'm guiding my patients after completing treatment on a follow-up plan, we have to make sure that these patients adhere to the follow-up plans. The first year is always after every 3 months, and you should come back and see your oncologist. But the challenge is the excitement of that first imaging that I am in remission. But the language and the communication that I really want to pass across to those who have undergone treatment, complete remission can only be concluded to cure after at least 5 years of follow-up. It is very important for us to know that. It's not with the first imaging, because, you know, there are many factors that influence prognosis. As we mentioned, you did ask Lillian earlier on about factors that influence survival. We talked about cost as one of them. You know, there is patient-related factors and there is disease-related factors, that all of them must be favorable for a patient to go through treatment with expectations of cure. So at this point in time, because we really want to give hope that, yes, it is possible to go through treatment, but we have to be careful. You know, as we, you know, hope for the best, we should also prepare for the worst, just in case there is a possibility of recurrence. And still give hope that even if there is a recurrence, there is still a possibility that you can be treated with still curative intention. I would use an example of ovarian cancer. You know, from statistics, from data, you know, using the conventional treatment that we are able to provide right now, ovarian cancer is one disease that responds to treatment after debulking surgery or after surgery, and you consider chemotherapy, it melts away.
Yeah.
But more often than not, more than 50% of them would recur. And of the 50%, if you subject to treatment, if it's been beyond 6 months, after treatment, you can still treat them with curative intention. So the emphasis that we're giving here this evening to those who are undergoing treatment, that they should adhere to their follow-up plan. And I want to ask that we should trust the healthcare providers, the cancer specialists who are within our hospitals, whether public or private, because we have built so much capacity now in our institutions that we should be able to trust that we can undergo treatment in this country with curative intention, and we should go into survivorship. All that we are asking is, please, if you are asked to come for a follow-up, make sure you come. We have a lot of patients who get lost to follow-up, and that's where there is a huge challenge. We conducted a study in Moi Teaching and Referral Hospital on children, and we found out that loss to follow-up was contributing approximately 23% of mortalities.
But that could also be an issue of the distance and the access that Phoebe was talking about. If you have to leave far-flung areas to come all the way to the Kenyatta University Teaching and Referral Hospital, to see your oncologist, then surely follow-up would be compromised.
And that is why, as a country, we are increasing capacity across our counties. And if we cannot provide a comprehensive cancer treatment center in every county, we are now setting up regional cancer treatment centers so that these patients do not have to leave Mandera or Busia or Migori to come to Nairobi.
Right.
They should be able to get care close home.
We'll be continuing with our conversation with our panelists. Remember, we are celebrating cancer victors, people that have beat cancer after undergoing successful treatment. And we are also very keen to know from our viewers why the rush to India. What is the rush to India all about? Do we trust our institutions here in the country? We'll be continuing.